Start with the mismatch. In a June 2026 JAMA Health Forum paper, Condorino and colleagues estimated prenatal care from electronic records. Adequate care was 76% versus 75.2% nationally. Early care was 68% versus 76.1%, a gap of 8.1 percentage points. Why can the same EHR network match one measure and miss another? Let's unpack it. Think of an EHR network as a live traffic dashboard. It updates fast, but may miss roads without sensors. Annual data arrive later, with clearer coverage. The authors adjust who appears on the dashboard, then compare it with national data. The question is whether faster information can still be accurate enough. The question is direct. Among U.S. adults with a live birth and prenatal care evidence in the EHR, can a large network support population surveillance? The authors check its distance from NCHS, stability across time and place, and what changes when the visit rule changes. Public health needs timely and representative data. NCHS is a key benchmark, but may arrive about 2 years later and has less clinical detail. EHR data are faster and richer. The trade-off is fragmented care and a network population that may not resemble the country. Speed still needs proof of coverage. This longitudinal cohort covered January 1, 2023, through December 31, 2024. Adults had a live birth at an Epic Cosmos facility and prenatal care evidence in the EHR. The authors tested 6 definitions against NCHS. This evaluates measurement, not treatment effects. The EHR cohort included 1,963,496 patients, mean age 29.5. The NCHS reference covered 7,224,951 live births. Nearly 2 million records reduce random error, but cannot restore people the network never captured. Prenatal care is not one clean EHR field. 6 rules ranged from diagnoses and prenatal specialties to encounters, procedures, and labs. Change the rule, and both the people captured and the estimate can change. Coding is part of the measurement. The outcomes were early care, meaning care started in the first 13 weeks, and adequate care, combining timing with enough visits. Each EHR measure was compared with its NCHS counterpart. The definition comes before the percentage. Think of a calibration chain. Raking weights adjust age, race and ethnicity, insurance, pregnancy risks, and region. Adjusted estimates are compared with NCHS. 2 one-sided tests of equivalence then ask whether the remaining gap is small enough to count as equivalent. After weighting, early care was 68% in the EHR and 76.1% in NCHS, 8.1 percentage points lower. Adequate care was 76% versus 75.2%, only 0.8 points apart and within the equivalence range. EHR usefulness must be judged measure by measure. Across definitions, unweighted adequate care ranged from 56.4% to 77.6%. With raking, the main definition settled at 76%. Weighting helps, but the code used to define the measure still shapes the answer. The same records can tell a different story when the operational definition changes. The authors also checked stability across time, regions, and groups. Adequate care was broadly stable, the early care shortfall persisted. Consistency does not prove perfect data, but it makes the direction of bias clearer. It also shows which measure still needs work. The conclusion is careful. A defined and adjusted EHR network can provide faster population surveillance of adequate prenatal care. Their word is supplement, add to current systems, not replace national data. The clinical detail remains an advantage, but that boundary matters as much as speed. For claims go too far. The EHR network is not the U.S. population. Early care remains low. Statistical equivalence does not make sources identical. This observational surveillance method study is neither treatment evidence nor personal medical advice. Those limits set how far the method can travel. The study lacked complete record or birth certificate linkage, and NCHS is not a perfect benchmark. People without EHR care evidence were excluded, Medicaid was underrepresented, and the cohort covered adults, live births, and one large network. Do not generalize it to every system, state, or unseen population. For the next EHR surveillance paper, ask 4 things: who entered the sample, how the measure was coded, what weighting fixed and what it missed, and how the benchmark and equivalence bound were chosen. If the answer moves sharply when the rule changes, do not rush to the conclusion. Measurement is part of the result. This paper does not say every EHR measure is trustworthy. Calibrated adequate care aligned with national data, early care stayed systematically low. Digital transformation must validate speed, representativeness, and measurement together. Leave one out, and a dashboard can be fast but biased. If you like journal explainers that unpack not only the result, but also the method and its limits, subscribe to Enan Tutor and turn on notifications. Next time, we will keep turning international research into evidence you can judge.